The 15th edition of the Maudsley Prescribing Guidelines in Psychiatry provides the strict clinical framework required to navigate modern psychopharmacology. It dictates the exact dosing, timelines, and drug interactions used by the Maudsley Hospital to manage complex psychiatric conditions. Managing bipolar disorder requires constant, high-stakes physiological negotiation. Prescribers must aggressively suppress mood polarity while simultaneously trying to prevent multi-organ toxicity from the drugs themselves. Lithium remains the primary treatment for this effort. It exerts broad neuroprotective effects across the brain, inhibiting glycogen synthase kinase 3, or GSK3, and actively promoting hippocampal neurogenesis. This preserves the neuronal circuits that regulate mood and stress responses, while providing long-term structural stabilization. This gauge tracks the required plasma concentration for lithium. The therapeutic index is narrow. For long-term maintenance, patients must remain strictly between 0.6 and 0.8 millimoles per liter. During an acute manic episode, that target is pushed to a maximum of 1.0. If the concentration dips lower, the medication fails to prevent relapse. If it drifts higher, it risks acute toxicity. Because of that toxicity risk, prescribing lithium requires uncompromising baseline physical monitoring. Clinicians must establish a baseline estimated glomerular filtration rate, eGFR, to track kidney function, alongside comprehensive thyroid function tests. These diagnostics are repeated every 3 to 6 months to catch early signs of organ damage. Despite prophylactic effectiveness that matches long-acting injectable antipsychotics, lithium carries high discontinuation rates. Patients frequently stop taking it due to tolerability issues, including tremors, polyuria, and weight gain. Lithium remains the most effective long-term treatment for bipolar disorder, but this status depends on permanent clinical vigilance to block irreversible neurotoxicity and organ failure. When lithium is poorly tolerated, prescribers pivot to valproate. This branched-chain fatty acid alters synaptic plasticity by inhibiting the catabolism of GABA and activating the extracellular signal-regulated kinase, or ERK, pathway. This flowchart illustrates it must never be offered to women of childbearing potential. The teratogenic risks are severe, and prescribing it requires enrollment in a highly monitored pregnancy prevention program. Clinically, valproate demonstrates clear efficacy in stabilizing acute mania. However, as treatment shifts from acute intervention into long-term prophylaxis, the data supporting its ability to prevent future episodes is significantly weaker than the evidence for lithium. Carbamazepine serves as a third-line mood stabilizer. Its use is complicated by autoinduction, meaning the drug actively accelerates its own metabolism in the liver. This forces prescribers to continually adjust the dose to maintain therapeutic levels. It also requires specific hematological monitoring. Carbamazepine carries known risks of inducing hyponatremia and agranulocytosis, requiring routine checks of urea, electrolytes, and full blood counts. Second-generation antipsychotics, or SGAs, like quetiapine and aripiprazole, provide an alternative class of treatment. These act as aggressive, dual-purpose agents capable of rapidly suppressing acute manic symptoms and maintaining mood stability. Moving a patient away from lithium monotherapy forces prescribers to navigate a minefield of physiological trade-offs, managing metabolic effects, strict regulatory warnings, and complex pharmacokinetic interactions. An acute manic presentation is a medical emergency. Intervention must be rapid, with pharmacological strategies deployed immediately at day 0. This decision tree maps the exact protocol for acute mania. For unmedicated patients, the guidelines recommend initiating monotherapy with either an antipsychotic, valproate, or lithium. The algorithm operates on a strict timeline. Prescribers cannot leave a patient on a failing regimen. They must evaluate clinical efficacy strictly at the 1 to 2 week mark. If the response is inadequate at week 2, the protocol mandates an immediate shift. The monotherapy phase ends, and the clinician must augment the current treatment, combining the antipsychotic with valproate or lithium. Combination therapy achieves stabilization faster than any single drug alone by hitting multiple receptor profiles synergistically. This creates a broader pharmacological blockade against manic symptoms. This phase requires rapid dose titration. Quetiapine may be pushed up to 800 milligrams a day, while aripiprazole requires a starting dose of at least 15 milligrams to ensure clinical effect. While these primary agents build to therapeutic levels, short-term benzodiazepines like lorazepam are frequently added to immediately suppress behavioral agitation. Achieving rapid stabilization in acute mania depends on these algorithmically triggered pivots. The Maudsley framework shows prolonged monotherapy trials in the face of ongoing mania are clinically obsolete. Bipolar depression operates differently than major depressive disorder. Episodes strike with faster onset and occur more frequently, carrying a severe 15% suicide risk. The combination of olanzapine and fluoxetine is statistically the most effective treatment for bipolar depression, outperforming standard SSRIs in clinical trials. Robust alternatives exist among the SGAs. Quetiapine, lurasidone, and lamotrigine have efficacy, allowing prescribers to select an agent based on the patient's specific tolerability for metabolic or sedative effects. This graph maps the danger of applying unipolar logic to bipolar illness. Standard SSRI monotherapy is heavily contraindicated in bipolar depression. Using an SSRI without a mood stabilizer carries a high risk of overcorrecting the depression and triggering an iatrogenic manic switch. Patients can also enter rapid cycling, defined strictly as 4 or more clear polarity switches within a single 12-month period. This state carries a higher incidence of anxiety disorders, addiction, and suicide risk. This checklist outlines the exact protocol for stabilizing a rapid cycler. Step 1 requires the immediate withdrawal of all antidepressants, which are known to accelerate cycle frequency. Step 2 forces a clinical evaluation of hidden precipitants. Clinicians must screen for undetected thyroid dysfunction or heavy alcohol use that could be driving the erratic mood shifts. Steps 3 and 4 escalate the pharmacological response. The prescriber must optimize the plasma levels of current medications and immediately begin combining multiple mood stabilizers, stacking agents like lithium and valproate together. Treating bipolar depression and rapid cycling requires discarding unipolar protocols. These standard antidepressant strategies fail to stabilize the mood and frequently trigger the very manic states they are intended to prevent. The cardinal rule of long-term bipolar management is continuity. Any drug regimen that successfully suppresses an acute episode must be maintained as prophylaxis, with the strict exception of withdrawing antidepressants once a depressive episode clears. This matrix maps polarity-specific prevention. A drug stopping mania doesn't guarantee stopping depression. Aripiprazole prevents manic relapse but provides no cover against depression. Lamotrigine prevents depression but not mania. Lithium separates itself as the only bidirectional monotherapy, blockading both relapses simultaneously. The guidelines establish a clear prophylaxis hierarchy. While lithium monotherapy sits as the first-line ideal, clinical reality, driven by tolerability issues, often forces prescribers to the second line. The decision to stop a mood stabilizer is usually forced by the accumulation of physical toxicities, such as chronic kidney disease, severe weight gain, or uncontrollable tremors. But cessation introduces extreme physiological danger. Abruptly discontinuing lithium rapidly worsens the natural course of the illness, bringing a high risk of manic recurrence. A straight, linear dosage reduction triggers relapse. Safe withdrawal relies on a hyperbolic taper, a curve reducing ergos significantly at first, then flattening into a very slow, long tail. This process must be stretched over several months, allowing neurobiology time to adapt. During this extended withdrawal period, prescribers and patients must maintain hypervigilance, constantly monitoring for the earliest prodromal signs of a returning episode. The Maudsley framework demands absolute precision from the first dose to the last. In bipolar disorder, stopping a drug safely requires as much clinical mastery as starting one.